So I'm Dr. Tim Staed, a pediatric emergency room physician at Cardinal Glennon Children's Hospital in St. Louis. There's also Cardinal Glennon was one of the hub hospitals for the first cohort and worked a lot with EMSC in various parameters. So, why are we talking about this anyway when there's so many children's hospitals around there? More than 80% of the kids seek their care in local community EDs, not in children's hospitals. And so it's important that the community hospitals have a pediatric readiness plan. And the National Pediatric Readiness Plan was implemented. And the goal is to have all of our community hospitals have a minimum degree of readiness for pediatric emergency care. Greater than 90% of these community hospitals are general EDs, and less than 10% really have even pediatric specific designated areas. And most of these see fewer than 15 children a day, which is not much. Next slide. So the children, they're not really on the radar screen for hospitals. Most of you who work in community hospitals understand that pediatrics come in, sometimes less than last in the hospital's consideration. They often don't have disaster plans. They don't have pediatric emergency care coordinators or PECs. And they'll just say, oh yeah, well, we'll take care of the kids because they just come in with ear infections and whatnot. And in fact, most of these kids can have significant medical problems. And if you're not ready, you're going to be in big trouble. And especially for the hospitals that are seeing less than 13 kids a day, they're not ready. And so the Pediatric Readiness Project the goal is to improve that number. Next slide. So the vision for the care of children in our emergency department is all departments should be fully prepared. And if you've seen the EMSC checklist, it gives you ER equipment, but the Readiness Project basically gives QI projects and areas of focus where we can improve our pediatric care in our community hospitals. Now, the children's hospitals theoretically should also be prepared for this, and most are certainly, but there's a surprising number of children's hospitals that don't have great disaster preparedness programs for their kids either. So there's a lot of work to be done in both community and children's hospitals.
Tim, it's Marianne, I'm back.
Oh, good. I'm sorry. I was just kind of filling in for you there, Marianne.
No, I got kicked off I had to go to a hardwired computer. So I really apologize, everyone. And Tim, thank you for filling in for me.
Yeah, I just stopped right there and you can take it over there.
Okay, terrific. And they're trying to admit me to the waiting room again here. Let me just make sure this is off. All right. Just 1 second, because I don't want to create a problem. I'm gonna go ahead and log out of that. All right, next slide. As you are all aware, the National Pediatric Readiness Project had its third assessment. This is the second assessment that was web-based. And you can see the response rate. This is from actually the previous assessment, but the response rate, which you're going to see in the next slide, is about 71%. This is during the pandemic. As many of you are aware, this is part of the multi-phase quality improvement initiative, is indeed the PRQC, the next round. So next slide. We began this process a number of years ago with the development of national guidelines, which began in 2001. Initially, the partners were ACEP and AAP, so the American College of Emergency Physicians, the American Academy of Pediatrics. But we got smart in 2009 and added our emergency nursing colleagues, because they're the ones who really do a large part of the quality improvement. And so that turned out to be instrumental in terms of launching the whole initiative of the National PEDS Ready project. And as you can see, EMS for Children has really been the funder of this. And then the sponsors include ENA, AAP, and ACEP. So phase 1 was the first national assessment, which included all of the United States and US territories in 2013. Phase 2 were quality improvement efforts, and there have been a number of collaboratives, and this is just adding to that quality improvement effort. And then in 2021 was the national reassessment that I just told you about. So next slide. So these are some of the results from the 2021 assessment. We had 3647 represents 71% of all EDs in the US, including US territories. And what we saw, and I think this is a reflection of what happened during the pandemic, I think, Tim, you were alluding to this in your comments, is that we saw far fewer children. So in the original assessment a number of years ago, I said that represented, at least 24 million children, and it's much less. However, what we see is that now 81% of EDs see fewer than 10 kids a day, unlike the data that Tim was talking about, which was from the previous assessment. Now, I will say that still it's shocking for those who work in a children's hospital to see how many few kids are seen in community EDs. But overall, again, most of the hospitals are community EDs or general EDs. And in this assessment, 98% of the respondents to the assessment were not in a standalone children's hospital. About 3% of the respondents, 2 to 3%, were in standalone children's hospitals. So you can see in terms of the recommended equipment, on average, the hospitals had 97% of the equipment. One of the fantastic, I think, wins from this program, as well as some of the quality initiatives, and we're going to keep driving that with this, is that 75% now weigh and record in kilos. At least that was what was reported. And so that's all good news, I think, overall, but we still have a little ways to go. In terms of mental health policies, competency evaluations, as well as quality improvement plans, there definitely have been some improvements. One of the challenges have been in keeping our PECs, or the Pediatric Emergency Care Coordinators, and you'll hear more about that and their important role in help driving this initiative and others. And what we found is that this went down pretty significantly, which I think resulted in a median score, which was about the same as previous, even though we improved in every domain except for the presence of PECs. And that's a nurse and a physician PEC, which has been recommended by the Institute of Medicine as part of what we need to have in order to improve pediatric readiness. Now it's called the National Academy of Medicine, but from the 2006 report on the future of healthcare in the United States, in order to ensure quality care for children, the IOM, now the National Academy of Medicine, did recommend a physician and a nurse PEC for hospitals. And so this is something where we saw a redistribution of this workforce to clinical care and care of adults in order to meet the needs of the pandemic. And again, how can EDs improve readiness? Getting a score of at least 88 is associated with significant improvements in survival. And then I already mentioned about the PECs, having a quality improvement plan, and certainly weighing and recording in kilos is going to help in terms of quality and safety. And then the other thing that we found is ensuring staff includes board certified emergency physicians or pediatric emergency physicians significantly improved a hospital's readiness. Next slide. So to dovetail with what we're talking about today is, again, weighing children or having an understanding about weight is such an important safety event. You'll hear more about this in a second. So as you know, we do weight-based versus standardized dosing. And I think, hold on one sec. And it's important. I just want to make sure my other computer was okay. The key thing here is weight-based versus standardized dosing. And so that's going to require understanding what the formulations are. And if everything can be pre-calculated ahead of time, this is also an important safety event. And I think measuring in pounds requires additional calculations, which create problems. And I know you're going to hear about that in subsequent slides. So the key thing is we need a process to ensure pediatric weights are measured and measured accurately, either by a gurney weight or estimated weights utilizing a length-based resuscitation tape, especially in times of resuscitation, are going to be key, and that they're recorded in kilograms only with that in mind, so that if a number is seen, staff understands that that means kilos. Next slide. Okay. I think we're going to oh no, wait, I'm going to, yes, thank you. So there's a couple of things that I think you need to be aware of in terms of position statements, not only by the AAP, but by ENA relative to this. And one of the things is measured, recorded, and displaying weights on the medical record so that everybody's on the same page in terms of what that number means. And that should just mean kilograms. One of the challenges that we found actually is that a parent would want to know the child's weight, and then they would change scales and put it into pounds in order to accommodate, the request of the families. But in actuality, just having a pre-calculated based on kilos table that could be handed out is really critical, and not necessarily leaving it to the vagaries of those at the level of the scale. And I mentioned the stretcher built scales. These are really common now. There's some that are built into floors, and I think that's fine. You can sit, and there's a scale, and then portable standing scales are what had been typically used for infants in the past. So clinical decision support functions can be used to compare entered weight and expected weight, and some real-time alerts. Those may or may not happen. And I think having a general understanding about how much kids weigh is going to be helpful, and I'll address that in a second. And then EMRs should be really designed for only entries in kilos, and this has been problematic in the past with the previous versions of the most common electronic medical records. Again, the actual weight is considered part, it's really like a vital sign, and it should be documented on each visit, certainly in the emergency department, and it actually should be in clinic settings as well. And then weight is included with any interdisciplinary or intradisciplinary handoff, and I think that's just part of good patient care. And then finally, for prescriptions to do weight-based dosing to document kilograms is also critical as a safety event. Okay, next slide. So when we talk about weight in kilos, what does this look like? You see the MGH method, that's after me. This is a way you can, what I call get in the zone. So 1, 5, and 10 years is 10, 20, and 30 kilos, and then you just extrapolate in between. So if you have a 2-year-old or a 3-year-old, they're in the range of 15 kilos. So I think this is incredibly helpful. So if something is documented and you go, what does a 5-year-old weigh? You know, the average 5-year-old weighs about 20 kilos. It's not perfect, but again, it gets you in the zone. So if you're off in terms of utilizing pounds somehow in this conversation, you'll have an idea of what is the true kilogram weight of a child about that age. So 1, 5, and 10 is 10, 20, and 30. Newborns, the average newborn is about 3 kilos. So a 6-month-old is somewhere in the range of 5 or 6 kilos. So you can see where this goes, but I just like the 1, 5, 10 rules, 10, 20, 30, and then a greater explanation later about ET tube sizing. So you want to measure, you want to know where does this occur? And again, what are the barriers to weighing and documenting in kilograms? Okay. And again, length-based measurement charts can be helpful in terms of a weight estimation. Typically, there are a number of different ones, but they're based on length of the child. Now, some of the children are greater than the length of the tape. So that means you're greater than 36 kilos. And so just be aware of that. They would typically be small adult size. But again, the key thing is many people have now the gurney weight or the stretcher scales. I think those are incredibly useful, and we use that all the time. Are there EMR controls in place? Is this something that you can reach out and talk to your IT about? I think this is really critical, and everybody has to be on the same page. We're trying to move as a country toward only kilogram or metric scale for both adults and children. And I think children, the care of children is leading this charge, but I think it's critical for adults as well as children. And then strategies for combating alarm fatigue. If you know there are alarms that occur if the wrong weight has been entered. And again, you'll have an idea whether this is a true alarm or if is it a false alarm based on some of the estimates that I've already mentioned. And the other thing is you can always look back on the medical record and see what had been previously recorded. So measure, then record, and again, think about, you know, what the processes are in place, what needs to be done, and what barriers each step, and then interpret. I mentioned the conversion charts when we had done this collaborative last time. What had happened is that this turned out to be a big barrier, is that parents would say, how much does my child weigh? And if you tell them your child weighs 20 kilos, that really didn't work well for parents. And so having the conversion chart where you show where 20 kilos is and then just hand it, just a handout at triage was found to be incredibly useful to keep staff from switching scales from kilos back to pounds. And again, does this number make sense? Is the MGH method just, does that make sense based on, say, understanding the child's age and years? All right, thank you for your patience. I'm sorry about my internet woes today, but at least I got to a hardwired computer. So thanks again, and I look forward to all the questions, and it'll be fun working on this. Thanks.
Thanks, Marianne. Yeah, that was terrific. So I just want to preface this by saying I am actually working in the ER today. So if you hear background noise, that's what's going on. So, you know, why is weight in kilograms so important? Basically because of medication errors. You know, little people big problems with medication errors. There's been loads of studies that have been shown that children are 3 times as likely to have medication errors. Now, not all of them are from weights. There's a lot of other reasons, but children are at much higher risk for a variety of reasons. In terms of weight-based medication errors, how do we get them? One is just the wrong weight. You know, the parents come in and they're like, oh yeah, we had them weighed last week, and the EMR shows that it's a weight from maybe 2 years ago, and they may be twice the weight they were before. And so if you don't really check and see when that last weight was put in, you might have something that is half of what they are. Marianne had mentioned calculations. That's a huge problem with kids. And I know a lot of people who work with adults and kids, their eyes kind of glaze over when they see all the ratios, the milligrams per kilogram and milliliters per kilogram and units and milligrams per mil times mil and it blah, blah, blah. And then another conversion trying to convert pounds to kilograms, it adds so many layers of complication that the errors creep in there very easily. But as Marianne had said, the biggest problem we had was just getting kilograms only versus pounds. Next slide, please. And why is that such a big deal? Because, you know, 1 kilogram is 2.2 pounds. So, you know, if you have a kid who's really 22 kilograms, we put 22 pounds, we're only going to give less than half the dose. The bigger problem, they're really 22 pounds, but we listed 22 kilograms, we're going to overdose them by a lot. So there's a huge switch in pounds and kilograms. You know, roughly 30% of our medication errors comes from this alone. So it's a huge deal. Next slide, please. I'm just giving an example of some of the common emergency drugs that you might see and what would happen if we had a medication error. So let's say the kid is 30 kilograms, which would be about 66 pounds, but somehow he gets listed as a 66 kilogram person. If we use the MGH method, again, Marianne, I like that a lot, that's terrific, then, you know, we would know that this isn't right. But drugs with a narrow therapeutic index, and I listed just some of them there, that if you double them up, you're going to get huge complications. Or opiates, you know, if you give twice as much fentanyl or morphine, or twice as much Versed or Ativan, or twice as much heparin, or twice as much insulin, all of a sudden you have a child who goes from sick to much, much sicker because of what we did. So those are just a few examples of the medications that can cause big problems if we don't dose them right. Next slide, please. So the timeline for how we got here, the Institute of Medicine report, as Marianne referred to, noted that children are uniquely vulnerable to medication errors. And it's not just the weight-based, but that's the crux of it. They have, you know, 30% of their medication errors come from that, and overall 3 times more than adults. Joint Commission then chimed in a year later, issuing a sentinel event alert. And then ENA also states, their policy stated, we need to weigh in kilograms only in 2012. Next slide, please. AAP affirms and reaffirms this, although I was interested, I didn't see that AAP actually put out a policy. They just said that they concur with the ENA. So I guess that's the same thing. And then in 2018, our first PRQC was launched, and there were 4 domains we worked on, and one was weight in kilograms. And our basic goal was to assist community hospital state programs in accelerating their progress to improve weight-based or decrease weight-based medication errors, and just increase the percentage of hospitals who are weighing in kilograms only. 2021, AAP again says this is a great idea. And here we are with our second Readiness Quality Collaborative. And again, weight in kilograms is playing a crucial role. And you saw on the previous slide that we had improved up to 75% of our hospitals who are doing kilograms only, but that means that 25% are not. And that's a significant amount. Next slide, please. From our first quality collaborative, we got a few good pieces of information out of there. When we have a large cohort like this, we can significantly increase the number of EDs weighing in kilograms only. That was demonstrated in one of Marianne's slide. What we need, though, is more data to demonstrate that this has an effect on medication dosing errors. The data we got was great, and you can presume that the more accurate we're weighing children, the better off they are. But when you put it into the statistical machines, we need more data. So we are back here doing this again. That's it. Thank you.
Thank you, Tim. Hi guys, my name is Heidi Ruff, and I am actually the Pediatric Emergency Coordinator here at Henry Mayo. So I am a Pediatric Emergency Coordinator at a community hospital in LA County. With that said, I'm not a big children's hospital, but my facility has taken it very seriously on taking care of our children and taking care of them safely and increasing our safety. So I wanted to talk to all of you guys about data collection. Who at your facilities will be doing this data collection? Have you assigned it? Do you have a PEC, a Pediatric Emergency Coordinator, or do you have someone who you're going to designate with those roles and those duties? Dr. Gausche-Hill alluded to it earlier, and thank you for saying this, that when they looped in the nursing side of things, they figured out that was a huge key piece to how to collect this data and how to do it well, because nurses are who are usually doing it in the background. So I can pull all the really good data, and then I can feed it to Dr. Gausche-Hill at the county level, and then we can make really good systemic changes. So who's going to be doing that? If your emergency directors and managers who are on the call, I'm going to say, I think you need to find someone in your staff who likes kids, who is passionate about pediatrics, and who's willing to take on this, because they're going to have multiple aspects of this. They're going to be able to see what's going on the unit and then help implement some of these changes. So that would be first things first, is who's going to actually start looking at your data. The next thing that I would say you need to look at is, how are you going to do this? Are you going to be doing manual data abstraction, which some hospitals do? Some hospitals still have to do manual data extraction because their IT isn't keeping up with their data. So it comes to play, the timeliness of the data that you can collect in order to start doing these studies. What is your hypothesis at your facility? And I think a lot of people think, oh, yeah, we're already charting in kilograms. And I think sometimes we surprise ourselves with when we actually go do the data and start looking at what's going on. And I can tell you that my crew and I did a study a few years back, and we had this amazing hypothesis, and we did the scientific method, and we proved ourselves dead wrong. So that's why we're doing all of this. What is going on in our hospitals? What data can we find in order to make things better? So then, once you've determined who's going to do your data collection and how they're going to do it, whether you work with your IT and you're pulling reports and you start looking at that, decide what your sample size is going to be. So are you going to do 100% of your charts? And I can say that I think 100% of our charts, with the amount of information that EIIC is looking at for us to do data submission, for me at my facility would be very, very, very time consuming, because we see about 1,000 kids a month here at our facility. So decide what size of sample you're going to do. Are you going to do 100%? Are you going to do 10%? Are you going to choose every 5th chart, every other day? However you choose to collect your data, that will be on your team and how you decide to do that. And then defining your sample. So who will you be looking at? Go ahead to the next slide. Once you determine the data you're collecting, and then the next thing is, what are you going to do with this? It does no good to sit in one single office, like to sit with me in my office and me not do anything with that. So when we start looking at weight in kilograms, and I think, oh, I think we already do this really well, and I start looking at data and look at it, and I haven't looked at my data, so I'm going to give you arbitrary numbers, and all of a sudden I'm like, ooh, maybe we only do weight in kilos 50% of the time, or maybe there's other barriers like Dr. Gausche-Hill had discussed earlier. So once you start getting your data, who are you going to share that with and how are you going to distribute the data? So for me, we're discussing that it would go both myself, and then we also do have a PEC physician. So my team lead as the physician, the ED manager, ED director, the charge nurse, and then we have leads on the floor that are other than charge nurses. So nurses that really love pediatrics and want to make things better. And then one of the other big things, and it took me a while to loop them in, but with pharmacy, how are we going to include pharmacy into this process? So that's where I start with some of my data distribution and some of my think tank of how are we going to do this? How are we going to do it better? What do we need to do? What do we need to do better? Go ahead to the next slide. So then from there, we're going to branch out our distribution to other stakeholders, other people in our facility who really care about our kids and care about giving better care to our kids. All of this starting with something simple like what we think is simple, weight in kilograms, in order to avoid medication errors. So we'll be branching out to emergency services committee, the emergency department staff meetings, pharmacy staff meetings, and then any pediatric committee meetings that you might have in your facility. Go ahead to the next slide. So you're going to make a plan, choose a QI plan. There's lots of them out there. There's lots of models out there, and see how you can make this work for you and your team. See how you can apply pediatric weight in kilos using one of these plans, and then see how you can affect change in your facility. So we'll start doing things like education, do some checks and balances, look at pediatric specific protocols. So what's our goal here at our facility will be to weigh 100% of our kids in kilos 100% of the time. I thought we had that down until I recently heard that mom came in and stated the child was 22 pounds and someone documented 22 pounds. So obviously that could lead to a huge error on a child because the staff didn't convert to kilos. So like both Tim and Marianne have said, we should have scales that are locked in kilos and kilos only. I was on the unit yesterday and there were a couple scales I just go over and happen to hit the buttons to see, what is it weighing in right now? And they were in kilos, happy to report. There are fancy things out there, such as integrating from your scale directly into your EMR. Our facility is not at that yet, but it is available out there. And then things like standardized equipment, standardized supplies. And last but not least, one of the things that I do want to hit on, and I know we do at our facility, but how was the weight obtained? Documentation of how the weight was obtained. Was it stated by the patient themselves or a parent? Was it obtained by a scale, a gurney scale? Was it an estimated via something like a length-based tape like a Broslow? So obtaining that information for us, because then I think that is also going to help us figure out where we need to improve our processes. And then I will tell you, we recently, literally recently at my facility have started with pharmacy verification of 100% of our pediatric medications. And I inquired yesterday to see how long, if that's adding a delay. And they said that the average time to verify medication by a pharmacist on 100% of our meds is 3 to 5 minutes. So I was super excited to hear that, and that we're implementing that here at my facility. I'm just giving you guys ideas. None of this is right, none of it's wrong, none of it you have to do, but just how can you start to facilitate this at your facility? Go ahead to the next slide. And then obviously, last but not least, what is our goal? Our goal is to increase patient safety, decrease medication errors, and then go ahead and share what you find. Like I told you about some of the stuff that I'm finding at my facility, because things that I find at my facility, and if I share and I'm transparent with you about it, then you could help implement that at your facility. Or you could say, oh yeah, we don't have a problem with weight in kilos, till you really start looking at it. And then you're going to say, there might be something a little bit more here than I thought. So as we come back together, as we have future conversations, don't be afraid to share what you found, because that might save another child's life. And that is the whole goal here. So thank you for your time, everybody.
Thank you so much, Heidi.
Thank you, Casey.
All right. So today you've heard from our presenters address patient safety related to weighing and reporting pediatric patients' weight in kilograms. For the sites who choose to focus on this bundle throughout PRQC, it's anticipated that you and your ED site team will focus your QI efforts on the following quality measure. These quality measures were created based on 25 national professional organizations, federal agencies, and regulatory agencies across the field of pediatric emergency medicine, looking at the most common clinical conditions and developing a crosswalk of evidence-based practices and critical clinical measures. Through a structured process, they were able to identify those most common conditions and measures. And the quality measure related to weight in kilos will be assessed when you start entering data into the data platform or the National Pediatric Readiness Quality Initiative. You may know this as NPRQI. So at this time, feel free to put your questions into the Q&A feature. Looks like we might have a few already. All right, so we have a question about going back to the NPRP assessment. I do see that it's for QI purposes only. Will there be a future date where every assessment will have been done since it's post-COVID? I think Marianne.
Yeah, I'll respond to that. Yes, it's definitely for quality improvement. And the whole idea is that once you participate and you see where your gaps are, that you try to fill those gaps over the subsequent time period. And the portal will be open, so you can reassess yourself at any time, which I think is really important. There will be another national assessment, likely in about 5 years. That is the plan, a 5-year cycle. We were 8 years this time. We were actually going to be less, but the pandemic hit and then we had to regroup. But we were still in the pandemic with this one, unfortunately, as it related to workforce issues. So again, you can put data in the portal. You can do it at any time. It can be ongoing quality improvement for you at your institution. And then the next national assessment will be in probably 2026, in that range. So thanks so much.
Thank you for the question and for your answer, Marianne. And I did put the website to go in and complete the NPRP assessment on your own in the chat. And then do you have a recommendation for a sample size or a minimum number of charts? I will, before we might hear from one of our experts, I will say that on the 15th of August, we will be having a session where we discuss an introduction to quality improvement and discuss data sampling as well. So we'll get into this topic in more detail soon.
For our
go
first,
ahead, Tim. Yeah.
Well, I was just going to say, for our first PRQC, we did the PDSA cycles. We'd seen a couple of different ways to do that, but we did PDSA and we would do 30 charts for each cycle. And we probably had 7 or 8 cycles, I would say, over the time. When you get beyond 30, it gets a little difficult. But Marianne, if you have another number, that's fine too.
Yeah, no, I was saying it really depends on what kind of variance you're expecting. Typically, we say a sample size of at least 25, so 30 seems reasonable to me, with each cycle. So I think in that range is probably reasonable. And then, assess, and then again, whatever interventions you need. Sometimes it's education, sometimes it's a structural change. Anyway, and then you can reassess. But it will depend on what kind of variability you have and what kind of change you're looking for.
And I would like to echo Marianne's experience about handing out those conversion cards. That made a huge difference in our hospitals too, in terms of acceptance of this, because the people would get frustrated. But if you just hand them the card, everyone seems happy. So that is a great place to start.
Right. Feel free to add any other questions into the Q&A feature.
Hey, Casey, could I mention one other thing? I think it's really important. And Heidi spoke to this. ED pharmacists, and not every hospital can have an ED pharmacist, but ED pharmacists actually made a tremendous impact in our hospital. I was going, okay, I got this. I don't need an ED pharmacist, which is absolutely lacks any humility. I was like, I realized that after one day of working with an ED pharmacist, I thought to myself, how could I ever think that we could do this without them? So I do believe ED pharmacists are incredibly helpful, and they can be just such an important member of your team on this. And so please include them. And even if they're not based in the ED, if they're based in the hospital and they come down to the ED, I think they're a great team member. And lastly, I think it's really important to work with pharmacists, chiefs of nursing, medical staff officers, ED, medical directors, about what the formulation you're using, because that is huge. And changes in formulation can lead to such crazy errors. And I'll just give you one example and then I'll stop. But midazolam typically comes in either 1 milligram per mil or 5 milligrams per mil. And so what can happen, obviously, if you change from the 1 milligram per mil to the 5 milligram per mil, you're going to underdose. If you go from the 5 milligram per mil, 5 milligram per mil to 1 milligram per mil, right? You're going to underdose, or you'll overdose on the flip side. So very important to understand what the formulation is, the typical formulation. And if possible, have everything pre-calculated is really the way to go. And we did that in LA County. We showed a reduction in medication errors. There was a standard way that a child was weighed, meaning using a length-based resuscitation tape in the pre-hospital setting. But in the ED, there's no reason to not use an actual weight. And the other thing is parent estimates may or may not be good. So I think that would be my last choice. People have talked about that. I would really, again, and most parents are going to report in pounds. So a conversion by almost definition, at least here in the US, is going to have to occur. So I would prefer an actual scale weight or gurney weight, and then the length-based resuscitation tape. Okay, I've said all my pet peeves in a very short time. Thanks.
And I had one other good example, the ketamine that we use in our ER. There's the 100 milligram per one, which we use for intranasal, or maybe IM, and then there's the 10 per one. So it's a 10-fold difference. And if you get those mixed up, huge problem. So.
Does look like we had one more question come into the Q&A feature. I'll read it out loud, and one of you are able to answer it. Let us know. What is the stance or recommendation for Diprivan drips on ventilated pediatric patients in the ED? I was thinking that most of the literature recommends against propofol due to the risk of PRIS, but I have a lot of ED dogs that automatically go to that when we have to intubate a sick kid. Looks like Marianne would like to answer.
Yeah, and I think, Tammy, you can comment, but I don't think there's any reason not to use them. So, the drips itself, and one of the issues are with really young babies. So I think that has been the big issue about any type of a syndrome related to use of propofol. So we have absolutely used propofol drips. So I think it's just the really young infants where it can be very problematic. So I'll let Tim respond too.
Yeah, I don't really have anything to add. I would agree with that completely. And for the very young infants, there's many other choices. Fentanyl drips are pretty common. Few other ones for the intubated newborns. So yeah, and they work great.
Thank you everyone for your questions, and to our speakers for contributing. Well, now I want to share some updates. Just another reminder to continue the registration process for NPRQI. getting that POA signed and submitted. We'll be putting the link in the chat, or you could use the QR code to get to the NPRQI registration if you haven't already. We anticipate sites will begin entering baseline data beginning of next month. So we want to make sure that if you have any questions, please reach out to Lisa or myself, and we will be happy to assist you in that process. And then up next will be our first collaborative session on the 15th of August, an introduction to QI and data sampling. So we'll really be branching off of what Heidi shared with us today and hopefully answering some of your questions and getting excited about starting to enter your baseline data. Our next two sessions again will be that session on the 15th. And then our final fireside chat will be on the 5th of September, looking at data literacy in a QI project. So registration is up on the website, and you should all received calendar invites for the session on the 15th and the 5th of September. This time, I'm going to go ahead and launch a session evaluation. At the close of that, we will be sharing with you the information for nursing CE and social worker CEU. Please take a moment and complete the evaluation. We'll leave that up for a minute for folks to go ahead and finish that evaluation. Yep, and if you haven't already, please put your first and last name into the chat. And here is the QR code for nursing CE. We'll drop the link in the chat as well. And if you have any questions, you can reach out to our contact, Robin Goodman. Give that a minute for everyone to get that information, and then our next slide will have the information for our social workers. Okay, and for our social workers, also make sure your first and last name is in the chat. Right, and then we do have one extra update to share with you all today. We want to let you know about the upcoming ENA conference in September. There's going to be quite a few sessions during this conference that are pediatric specific. So we hope if you're in attendance, you'll be able to stop by one of our sessions and see a member of our team. Thank you all for joining today's session. If you have any questions, feel free to reach out, and we look forward to seeing you on the 15th.